It will be difficult for some here have finished eating. So can we ask questions? Those are yeah. Any questions? Any queries? Yes, go ahead, sir. Any yes. Again, hypoplasia, like I explained to you, lung development continues until 8 weeks. Now, the key here is that that patient must have the personnel and the machine to provide mechanical ventilation. You don't rush in to go and do surgery, remove intestine from the chest cavity, and forget that that baby will need to do what? The lungs, the small lung that is at the plastic that is developed, need to be expanded. You remove the what's the causing obstruction and forget to expand the lungs. What do you think happened to the baby? The baby will become cyanosed, and the essence of surgery will not be achieved. So the key word here is that that lung that is remaining must be ventilated. Now, if you, okay.
Because it's a very technical question, and this is really the problem. Is teamwork. We're going to the next one. And the first thing you will hear is that the most important muscle of ventilation is
diaphragm.
When this diaphragm is not touched, if you touch, you will have a problem. So the moment you go and do the surgery, you're going to give something that would paralyze the muscles for a while. So what do you think will happen? The most important muscle of ventilation in newborns is the diaphragm. So if you have a congenital diaphragmatic hernia and you go in for surgery and you will now lock up the place and picture, you're going to give something that will have, even the ventilation is congenital. I worked a while in a place called Cincinnati Children's Hospital. It's one of the designated places for CDH in the US. The ventilator setting for children with CDH is different. Before repair, and you cannot give the child nasal silver. Because if you give him nasal silver, what do you think will happen? He will continue to increase the intra-abdominal pressure and continue to push the gut into the lung, into the thoracic cavity. So the cycle is not, and so for you to go and do that surgery without having very clear conversation that you're going to need to take over this ventilation of this child is a crime. So this is where it meets
West.
There must be very clear conversations. How big is the hole? How long are we going to paralyze this child? What pressures are we going to use? Because I have a child that I think they were just talking on the corridor. The only thing I was the pragmatic of the machine started with the child and ended with the child. The child survived. But the machine spoiled. Yeah, the child survived. That machine not able to fix like 5 years. So CDH is not a child's play.
Not.
When we say CDH and you say we're going for surgery, I'll tell you though. When you finish, let's see. So it's a very technical question you ask, and we need to have more robust conversation. You said there are some times we see the conversation we have. Oh, yeah, let's go in. I say you're not doing it. Let's wait. Thank you very much for that. We have
Okay.
another one.
Any queries? Any other questions? Okay, we'll go to the next class quickly. And then, as we are eating, please pay attention. It's a walking tea break. So, in this module, we aim to understand respiratory signs and their origin. From multiple organ system to the newborn, we look at the clinical assessment tools we are going to use, their scoring and the classification of respiratory effort. This is very, very important. Because somebody will soon tell me they don't have blood gas, they won't be able to ventilate. If you don't understand Sir Anderson's scoring system, you won't be able to communicate with me. Now that I'm in Yola, so this is Yola, and somebody is in Asaba with my machine. You won't tell me, you won't be able to communicate with me. The baby is not breathing somehow. It does not mean anything to me. Are you with me? And the doctors will say, the nurses have done the scoring. It's a fight, so we understand how to score. Are you with me? Are you with me? We understand the assessment of newborn respiratory failure for respiratory support assistance. I want to tell you that newborns are always talking to us. We are just not paying attention. And we will pay attention after this class. Is somebody listening? Okay, let's look at this case. The baby is one day old, was weighing 2.25 kg, delivered at, is it a preterm baby? Delivered at 37 weeks, is it a preterm? In a private hospital by elective CS, presented with poor care at birth, difficulty with breathing, apnea, had meconium stain cord, the heart rate was 156 beats per minute, and the child had 102 cycles per minute respiratory rate. There was intercostal recession, subcostal recessions, substernal recessions, and the chest bulge, and the respiratory was 98% on oxygen. This is the vital, this is the chest X-ray. What is happening here? What can you see here? And some people who have finished eating now, they can pay attention to this one. So what are you seeing in this chest X-ray? Where is the stomach here? Where is the stomach? Can somebody point to the stomach? What is this? Eh? What is this? That's the gastric ball. That's the stomach, right? Now, this is the right. Where is the heart? So we'll discuss this in more time. How many of you have seen babies like this? Actually, not other one as a video. Now look at the first day of this child. Look at the third day of the child. So if you look at these pictures now, is baby worse here or worse here? The baby became worse on the third day of life. Now look at the fourth day of life. Where is the bulge? Where is that thing? So the problem is, what was the cause of the chest bulge? That's question number one. Question number two, what is the name of the chest bulge? Was there anything wrong in the labeling of the X-ray? Then what happened to the left side of the lungs? What treatment was given to this child? I want to ask this last question. Do you think the child got any treatment? Who thought the child got treatment? Or we left the child on oxygen? I bet oxygen is a treatment. Shall we go back to the question again? Okay. So some people want us, I don't know, we will be very fast though, so that we can finish the class. Okay, so what's the diagnosis here? What's the diagnosis? Okay, what are the point TTN? The child has the meconium stain cord. And the child received something on the third day and got better on the fourth day. So what did the child receive on the third day? So that means you're paying attention to the previous class. Are you with me? See, some of these things are, I'm sure that the chief manages this patient. Chief, this is your patient, right? That is the patient you manage. Imagine if he was not around. If he was not around the hospital and traveling somewhere for this training like this. What do you think that was happening to the baby? And no other person had knowledge. What do you think happened to the baby? What will happen to the baby, sir? No, the baby has not died. They don't die quickly like that. What will happen to the baby? Somebody will continue with what? Oxygen. Will the baby get better on oxygen? That's the essence of this class. Somebody will have continued giving the baby improvised CPAP, improvised CPAP. We'll discuss CPAP later. Or oxygen. I've gone to the hospital where, even in my hospital, I came one day and say, why are you giving, they use master oxygen cannula? This is Terrible respiratory distress. Somebody who's oxygen, normal oxygen tube. What do you call it here? It's not oxygen tube. Nasal prong. Don't put the baby like that and put on oxygen. I said, are you treating the baby or are you making them pay more money? Because if baby has a respiratory problem, you provide respiratory support, not oxygen. We'll discuss that later. Okay, so the patient had meconium aspiration syndrome. They see surfactant on the third day and got better. Are you with me? So important, it's very important to be able to understand the manifestation of respiratory illnesses. You must understand that. You must examine babies. There's something like you are passing and somebody has given you a summary, especially for the senior doctors. They are giving you a summary. Whether the summary is correct or not, you not see the baby, you make a diagnosis and type everything. If they are told, if Dr. Konko and Professor Angelo Kolo, who are my mentors, told me that newborn management requires, there's no office. Your office is the bedside of the baby. Are you with me? If you are going to work in the newborn and the NICU, your office is the bedside of the baby, because without monitoring this child, no matter the intervention you give, you will not have a positive outcome. That is why I say to the nurses that the bedrock of NICU care is the input that comes from where? The nurses. Let me say it again. So you are not an ordinary person, not walking around the NICU.